Good morning and welcome to the Public Health and Minority Health Disparities Subcommittee. For the record, I'm Chair Delegate Heather Bagnall. It is January 23rd, 11 a.m., and we are here having a briefing from the Cannabis Public Health Advisory Council. Elizabeth Crom and Dana Moncrief will be presenting today. And Ms. Crom, if you want to go ahead and introduce your team.
Sure, thank you so much. Good morning, I'm Elizabeth Crom, and I'm the Director of the Prevention and Health Promotion Administration here with the Maryland Department of Health. And Dana, why don't you go ahead and introduce yourself?
Of course. Thank you, everyone. I'm Dana Moncrief. I'm the Director for the Center for Tobacco Prevention and Control at the Maryland Department of Health.
And we also have joining us today our Deputy Secretary for Public Health Services. Nilesh, would you like to just take up mute?
Absolutely. Good morning. I'm Dr. Nilesh Kalyanaraman, the Deputy Secretary for Public Health Services at the Maryland Department of Health, and I'm joining my two colleagues as they present.
Thank you very much. Welcome to the Public Health and Minority Health Disparities Subcommittee. And if you want to go ahead and get started.
Perfect. Thank you so much. And Dana, do you want to go ahead and get the presentation? Okay, hop along to the next slide. Okay, so thank you very much for the opportunity to speak with you this morning. We have two parts to our briefing. We're going to begin talking about the Cannabis Public Health Advisory Council and its work. And then we're going to share an update with you on what the department's been doing to implement the public health response to cannabis adult use legalization, including a really brief snapshot of our developing data dashboard. We'll move to the next slide. Great. So, Dana, can you go to the one after? I'm sorry, go back to the one that talks about where it started.
This one? The purpose?
Nope, the one you just passed.
Sorry, this one.
There we go.
Okay, sorry about that.
All right, so we're going to start first with the Cannabis Public Health Advisory Council, and this is what I'll refer to as the council in the presentation. So as you know, the council was established in 2022. The Department of Health staffs the council, and then Governor Moore appointed members in mid-July of 2023. And we're thrilled to have Delegate Hill with us on this group. We did provide a complete roster of the council at the end of the presentation for you to review. Up to the next slide. So in terms of the purpose, the council serves in an advisory capacity and makes recommendations to really advance public health related to cannabis use and adult use legalization. The full scope you can see on this slide, and it's a lot. So instead of reading it all, I think it's helpful to think of this in terms of three buckets. Basically, there's prevention. So the group will advise and provide recommendations on prevention of use, misuse, and addiction, especially for those who are under the age of 21, but also for other segments of the population, such as pregnant persons or those who are breastfeeding. There's also monitoring and surveillance, or you could just say data, how we monitor trends, how we assess the impact of the legislation and the legalization on the health of Marylanders, how we utilize this information to actually tailor interventions and campaigns and partner with our communities. And then the third bucket would really be research and training. So what's needed to reduce the appeal of cannabis to minors, standards, requirements around packaging, labeling, advertising, training for healthcare providers, and others. So that's really sort of all those words rebucketed into those three buckets in terms of the councils, where they're studying and what they're making recommendations on. Now to the next slide.
And the HB 70 Blues.
So the council really hit the ground running after being formed in mid-July, starting with its first meeting in August. You can see a summary of their main activities here on this slide. The group decided to start with forming two work groups, really based on a review of their charge. And the first one being youth mitigation, so basically prevention of youth use, and then data and surveillance. Additional work groups might be established in the future, but these were really seen as the most important ones to get up and running, given the importance of preventing cannabis use by youth, and then also the need for data that can be turned into information to shape our public health response. So one of the things that the council was able to accomplish was the completion of its first recommendations report. So this has been finalized and is just in the process of going through review here at MDH. The full list of recommendations we did put at the end of the deck if you wanted to look at that in greater detail. But this slide shows you really the categories of the recommendations. So we had broad recommendations related to education campaigns, programs, and interventions. For example, the recommendation to establish education and training programs on cannabis use and impaired driving, increasing resources for problem use cannabis, and supporting more supportive resources for those who want to help quit using cannabis. Another sort of broad recommendation example would be funding educational campaigns to always lock up cannabis and to increase awareness around licensed versus unlicensed products. We also had a few very specific recommendations. For example, adding cannabis-related questions to existing surveys that support our general surveillance. So examples of these surveys would be our youth behavioral risk survey. We have a prenatal risk survey that's also used in the state. So actually adding specific questions related to cannabis use on those surveys. Another specific example was actually a recommendation to require dispensaries to keep affordable lock boxes for sale and on display during all hours of operation. And a third example, just to show you how granular some of the recommendations did get, was that recommendations to study the impact of high potency THC products, that's the tetrahydrocannabinol, that element of marijuana, on both short and long-term mental health issues. So, and as you'll see at the end of the slide, there were also several gaps in data that were identified that the group would like to see addressed. And so that's something that we're working on too moving forward. So some general things, some very specific items that action can be taken on now. And then also a big chunk of this is related to data monitoring and surveillance. The council drafted its action plan for calendar year 2024. And actually in the meeting that was held in January last week, the group really started to flesh out their priorities and identify areas where there were any knowledge gaps. So this is really a learning group too. So in order to study this and then make recommendations, there's a bit of knowledge transfer that needs to happen. This also then allows us to plan for this year to figure out who we'd like to bring in terms of experts, presentations, invited guests. Last week, we actually had two presentations. One was on the Youth Behavioral Risk Survey, what it is, the questions, how it's done, and then also a presentation from Motor Vehicle Administration on impaired driving, distracted driving, their data sources, how all that works, and how we can work together with them. So that really provides you a very quick overview of the council, what it's been up to and what it's done thus far. And I'd like to turn it over to Dana to talk about what the department's been doing to work on the really public health framework of cannabis.
Okay, well, thank you, Elizabeth, and thank you again to the subcommittee for inviting us today to discuss the cannabis public health efforts. So the Maryland Department of Health is building a statewide program to address the public health impacts of adult use cannabis legalization through the Cannabis Public Health Fund, of which the department manages. As you'll see on this slide, we've been working to develop our program around the framework, drawing upon best practices and lessons learned from addressing commercial tobacco use as well as alcohol. Also looking at modeling after other states and looking at evidence-based guidelines, particularly from the Centers for Disease Control and Prevention. The CDC does have a public health cannabis strategy, which you'll find in Appendix 3 to the slide deck. And looking at the specific pillars, it talks about monitoring trends, advancing research, building state and local capacity, supporting providers and health systems, partnering with public safety, schools, and communities, and improving public knowledge and awareness. When looking at tobacco control programs, there is a comprehensive framework for addressing tobacco control at the state level. And that is kind of in alignment with the pillars I just mentioned. So state and community interventions, mass reach media and communications, cessation and health systems interventions, and of course, as we've discussed, surveillance and evaluation. So public health framework for adult use cannabis legalization, items that we want to look at is preventing youth use, misuse, access, preventing cannabis use disorder, ensuring equitable access to behavioral health and substance use disorder treatments, ensuring quality management of programs, again, through data and surveillance, providing training for healthcare providers, and engaging communities to achieve, health, I bumped the keyboard, to achieve health equity. So many states that have legalized cannabis for adult use also follow this public health framework and evidence-based strategies, and Maryland is doing the same. Again, preventing youth initiation and access, preventing youth use among pregnant and breastfeeding persons, protecting from injury, as we discussed, drug driving, and unintended ingestion, safe storage, reducing exposure to secondhand cannabis smoke and vape, promoting social equity and healthy communities, and broadening the evidence base. So these strategies are certainly in line with what the council and the recommendations that they have made. Looking back to the slide here, you can see what we've done already. We're working very closely with the Maryland Cannabis Administration. We want to make sure that we have complementary messaging and a concerted effort. So we are joining with the Cannabis Administration on a statewide media and outreach campaign. Currently in the field, we are focusing media on drugged driving, keeping cannabis locked up away from children and pets, and smoke-free public spaces. We're also funding a new, and I think first of its kind in the country, a Cannabis Public Health Legal Resource Center. And this is really to help partners, legislators, local health departments, others, to really help navigate the ever-changing public health cannabis environment. And we are looking to support local health departments, schools, and data and surveillance. And then I just wanted to preview our data dashboard that we've been working on. We are working closely with the Secretary's Data Office, again, looking at these public health measures and the impact of adult use cannabis legalization. We have the data sources here. I won't read through them, but we are compiling emergency room visits related to cannabis use, inpatient and outpatient reports of cannabis-related health incidents, mortality rates, adult and youth use during pregnancy, and even call volume to poison control centers related to cannabis. So these are all the things that we are compiling. Of course, this will be for internal monitoring of our interventions and evaluation, providing data. We really want this data to help guide policy-making decisions as well. And there will be a public-facing option. And just a quick preliminary view, we pulled out just the snapshot here of our youth risk behavior survey. So these are items that we have started to pull together. So % of kids who have ever used marijuana, who are currently using marijuana or cannabis. And then even getting into % use by race, by gender, by age, method of use. So these are, again, preliminary views of our dashboard that we are continuing to work on over the next few months. And that was everything I had.
Thank you very much. I'm going to go ahead and open it up to questions from the members. I'm not seeing any hands. Apparently you did an extraordinary presentation. I had a couple of questions, and you spoke to this a little bit, but in terms of as we're looking at the data and as we're looking at prevention efforts and safe storage efforts, how are we looking at this through an equity lens to ensure that that we are providing resources to communities in prevention to make sure that communities are not being adversely impacted. The communities that have historically been adversely impacted by the criminalization of cannabis are not now being adversely impacted by the decriminalization and recreational cannabis.
So that's a really great question, and I'll start with a response, but I'm sure Dana will have something to add to this as well. So one of the things that we are doing is conducting a needs assessment in terms of trying to really gather across all the different jurisdictions, what are their needs regarding prevention, education, awareness, all the way down to treatment needs, et cetera. And then we will have these dollars out to local jurisdictions within the next couple of months, if not maybe a month, actually planning money. So to put the power in local communities, so through the health departments to look at their data, have conversations with their own communities to determine, what is the best way to work with the school system, for example, or to work with public safety, and have them create those. We have, examples of evidence-based approaches and practices and interventions that have been used in other states that have come before us in legalization. But we really want the local jurisdiction to be able to decide based on the available evidence of best practices, plus what's right for their community, to mash those two together and make a decision on interventions. So that's the first part to it. But Dana, I'm sure you have more to add there.
No, I think you did a great job. And, with our data dashboard, we are trying to get down to the local level. So we can do that with our youth risk behavior and our adult use, the BRFSS data. So we are looking to try and get more granular. So as Elizabeth said, we can help local health departments guide their programs and reach populations, certain populations. I will say too, with the media contract, we are able to do surveys, focus groups to really compile and learn more specifically within these types of spaces. So we can, even with our media and our outreach, really focus and tailor messages that are going to reach populations that you mentioned.
Thank you very much. And I see a hand from Delegate Lewis.
Thank you, Madam Chair. Thank you, Ms. Crom and Ms. Moncrief, for your presentation today. It's so interesting to watch in real time a new sort of bureau come into being before our eyes. So I want to commend you for doing the heavy lift. It's really impressive. And also thank you for making sure we keep a public health perspective on all the work we do around cannabis. It's so important. I actually have a two-part question. I don't usually do that, Madam Chair. I think I've been affected by Delegate Hill, but if
We're going to allow latitude. This is our first opportunity to really sort of wrap our arms around the work of as you said, this newly formed entity. So
yeah, thank you. So my first question is, on the slide number 8, I think it is, under MDH efforts, you refer to the creation of a cannabis branch. So there's lots of entities coming into being. You guys are the Public Health Advisory Council team. How does that differ than the cannabis branch?
Sure. So within the department, we have received the Cannabis Public Health Funds. So within the department, within our administration, we have developed a cannabis branch. And that's, again, to manage the funds, to review all the items that I discussed, all of our projects. Separately is the Cannabis Public Health Advisory Council. So my staff does provide technical assistance to the council as they meet and assist, of course, with reports and other items.
Okay. So these are sort of side-by-side entities. I'm just trying to get a picture of the org chart. Okay. And the cannabis branch, it doesn't just include people working on cannabis, right? It's, who are the folks, experts there?
Right, and branch might have been, it's sort of our internal jargon here, but so the Prevention and Health Promotion Administration has a Cancer and Chronic Disease Bureau. And within Cancer and Chronic Disease, we have a tobacco control program unit area. And that is what Dana oversees. And given how similar the public health response for cannabis is to tobacco, many of the prevention strategies and the framework are very, very similar. We have put the staff that will be working on cannabis under the tobacco control programs area. So it's like a little branch within the larger tree of tobacco control programs.
Got it. And that makes good sense. It's a good way to leverage resources you already have. Okay, thank you. That helps my visual mind picture the structures. And then my second question, if I may, Madam Chair, it's about the Cannabis Legal Resource Center. And as we're thinking about equity and making sure that this brave new world where cannabis is part of, sort of operating in the light legally, one way to look at equity perhaps is to look at how many people are facing legal challenges. So I'm wondering if the Cannabis Legal Resource Center at UNB is able to report to us on the number of people seeking their services for legal advice, what sorts of cannabis-related legal questions are coming up. Is there a pattern? Are the laws we've passed being faithfully implemented? Or are there opportunities for us to do things better? I know you guys, that you have a recommendation mechanism, but I'm just curious about that Legal Resource Center. What do we know about what they're seeing and hearing so far?
Yeah, so the Legal Resource Center, we've just got that up and running. They have a similar center. It's actually, this is going to be part of the larger center. It's Legal Resource Center for Public Health Policy. They have a big focus on tobacco control. They provide legal technical assistance. They do not provide legal services. So that's a very important distinction. But they do, of course, get questions that come in from the community or residents. So I'm sure we could reach out to them and see what kind of questions they are getting and that we could provide to the committee.
Thank you. Thank you, Madam Chair.
Thank you. And we would very much appreciate if you're able to reach out and just share that information with the full committee. Delegate Rosenberg, did you get your question answered? All right, Delegate Chisholm.
Thank you, Madam Chair, and thank you for the presentation. I'm just curious about something. On page 10 of your handout, I'm looking at the charts, and is there a reason why the chronological graph is out of order? Like you do 2016, then 2013, 2014, 2018, then did we do up top 2014, then 2013, then 2016? I'm just curious about that, but more importantly, if the graphs are correct, and it's hard for me to see these colors, I'll be honest with you, it looks like by percentage ever used marijuana by race, white is the top percentage. If I think I got this right, and then it's black, and then I don't know what the dark brown. Am I looking at that graph wrong?
So there's no good reason for why those numbers appear the way they are, and that's why we noted it as a preliminary snapshot. We're still in the data validation process and also visualization. So what you're seeing is a very raw cut of things, and not what will be the final dashboard. So you are right in noting that the numbers kind of all jump around. But in terms of the actual takeaway from that data, Dana, do you want to speak to that?
You're still on mute.
I am, sorry. I was just trying to pull up the slide. So, right, so you see here, you said it was the slide for cannabis among high school kids. Is that what you were looking at? I'm sorry.
Yeah, I think it's slide 10. If you look at the bottom, it says ever used by race percentage, and then currently used by race percentage. because the white and the all other races and Hispanic, they look like similar colors, so it's hard for me to tell, but it looks to me like white would be the highest percentage.
Yes, according to this, yes, it does. It says ever used, so if they've ever used in their lifetime. So yes, the white population is the highest percentage in both of these charts
So
here.
ever used and currently.
Yeah, so current use is within the past 30 days. Ever use is have they ever tried it in their lifetime?
And I think the challenge for you guys is really the same as polling. Who's being honest, who's not being honest, what's the sample size? It's kind of tough to tell, but I appreciate the answer. My only suggestion would be, I know this isn't you, use more contrasting colors.
Yes,
Reds
yes.
and-
of course,
Sure.
yes.
Perfect. Thank you.
Noted, yes, thank you.
Thank you, Delegate. Delegate Hill.
Thank you, Madam Chair, and thank you for the presentation, ladies. I feel a little weird asking a question or commenting because I'm on the commission, but some of this information is still new. And I'm going to go back to the chart that Delegate Chisholm was just asking about. I think those numbers are the percent of 100%, right? And I'm wondering, in other words, what percent of the people, the kids who say they use are Black, Hispanic, so on forth. And I'm wondering if the real numbers we want to track is within each group, what percentage of white kids use, what percentage of Black kids use, what percentage of Asian American kids use. I don't think that the percentage of the whole has that same value, but I wanted to ask about that.
Right. And so what we have to do, and this is a part of the validation process with this data dashboard, is we also need rates because when we can disaggregate by race, we also need to think about the percentage in the population and by jurisdiction, and then look at use within that race and sort of the right percentages. So what you're identifying is sort of what our next level of work is within this data validation and presentation process. And I was just, I don't know if we have a copy of the larger dashboard that we might be able to share, but if you want to respond to that one, the other part of the delegates question with the tally.
Yes, I don't have everything right in front of me, but it's certainly something we can share, especially with this youth data and the adult data. We just collected, well, this data is actually from the 2021-2022 school year. We just finished collecting data for the 2022-23 school year, so that should be coming out soon. But we definitely have some further charts and information that we have things broken out separately from this dashboard that, we'd be happy to share with the council or the committee so that we can definitely show, larger picture, more data points that we can share with you all. I'm happy to do that.
And I guess the question is really, because you're right, the data, we gather data based on the information we want to act on. And so if we go back to panel 3 or slide 3, it speaks to, let me go back to it. There was an issue with how we're targeting our messaging, and it made the point to say that we're targeting, adolescents, young adults, older adults, persons who are pregnant and breastfeeding, and racial and ethnic minorities. And separate from the chair's question about how we're making sure that we're not going to continue to have disproportionate impacts, the targeting of messaging to racial and ethnic minorities, and then the gathering to talk about what percentage of folks are using. I think it's, again, if we're not looking at how we're gathering the data, I think it's actually setting us up to do potential damage, because target populations for consumer awareness information, I'm not sure should be racially and ethnically divided, but there must be a reason that the data group has decided to do it that way. We know that previous studies, when all this was illegal, showed proportionately similar use among, and particularly in Baltimore, among in this area, among whites and blacks. It didn't speak to other minority groups. And the issue that we addressed as a General Assembly is, if the use is the same, why is the involvement with the legal community and the punishment so disproportionately meted out? And it seems as though in some ways the way we're targeting and the way we're approaching the data, we may be reinforcing the same things, that somehow use, whether it's 30% of the African-American population or 50%, if it's also 30% of the white population or 50%, then the significance and the seriousness of the public health effects, we ought to be treating differently. So I guess I'm asking if I'm reading this wrong, but this presentation is raising some concerns to me that we may be sort of following similar patterns that are going to lead us to misdirect resources.
I understand your point completely, and I think let me back up a step. So we wanted to show, as you can tell, I mean, we're standing this up, we're getting the committee going, we're standing up the branch and everything else. And so a lot of this work is still in process. We also want to be responsive to the recommendations that are coming from the committee as it's meeting. So in previewing that snapshot, and great, because we can then see data, it also leads to many more questions. So, what we were trying to do was take the advice of the council in terms of what were the items and the sort of data points that were necessary to think about surveillance and monitoring writ large for this issue. How could we get our hands on those data sources? How could we knit them together? And then how can we actually make sense of it? So what you're seeing, I just wouldn't spend too much time going down into the individual data points there, because what you're seeing is a non-final version. The questions that you're asking, however, are exactly the right ones to ask of the cleaned and validated data for us to then make programmatic decisions on. So what will be coming shortly, and what you will see, Delegate, as a part of serving on the council too, and if you pop back into the data work group, we get down into the weeds a little bit on this as well, in terms of how to make sense of what these combined data sources are telling us, to your point. So that is work to come. Yeah.
All right. Thanks, Dr. Crum. And that's the point, because I'm on the youth work group, so I don't hear the discussions.
Yep.
And so this is my seeing the data, and I'm concerned about the direction. And I understand this is preliminary, so that's helpful. And then my final point, if I may, Madam Chair, if you look on the slide that talks about the directives from HB 837, one of the things I think both of our presenters will confirm is there's been this focus, almost by charge, on youth use. And at least in the youth subgroup that I work on, we have consistently and persistently had to raise the point that there are potential public health effects across ages, and that we don't want this committee to ignore public health effects for adults. And I just wanted to raise it to this subcommittee, because I don't want to be, I'm not the only one on the council who keeps pressing that. What about other people besides youth? And the council's been responsive, but I want to make sure, there's a catch-all in the legislation, the statute, that says in other public health effects. But I want to be sure for this subcommittee that the sense of the subcommittee is we are also interested in the health effects of adults as well. Thank you.
Thank you, Delegate, and that is well noted. And I appreciate you keeping an eye to that we need to make sure we're keeping the aperture wide and not just focusing on the youth populations, because we do work on population health. Delegate Riley.
Thank you, Madam Chair. Appreciate it. Thank you for the presentation we've heard today. I previously have experience sitting in a parking lot and watching, teenagers, because they were talking about going back to school, teenagers actually smoking marijuana in their cars and then driving away. And currently under, our current law, so I'm kind of like targeting on the, the driving impaired portion that we're trying to get proper data on. So since we have so many limitations, or law enforcement has limitations on what they can and cannot do for those people that are smoking while impaired, whether they can smell it, you have to have probable cause, and the smell is not a probable cause. And so how are we getting clear data on what is happening with our impaired drivers if we're limited on how we obtain that data? And I was curious, kind of a follow-up to that, with the conversation or the meeting that you had with the MVA. Are they having concerns with that, or did they have suggestions of how we could maybe tweak the current law or change the way we're going about it? If you could just maybe, give us a little bit of information what happened at that meeting with the MVA. Thank you.
I'd be happy to take that, Delegate Riley. So this issue is really an important one for us and for MDOT as well. In discussions with them, this is a challenge throughout the country, right? There isn't a good definition or standard for for how to test for cannabis and how to make the determination of what level constitutes impairment. Same way we have for alcohol, not similar, sorry, dissimilar, right? Alcohol, we have much better way to measure that. And there's more standardization around that. And so the impairment question comes down to judgment of law enforcement as to what constitutes impairment. And so we're still working on that. I've had conversations with our partners at MDOT and MDA around this question. We're going to be following up on this and trying to understand how we can move the needle forward on this. And I think the other question is how we can move the needle forward on understanding the data that's collected from our law enforcement officers, right? Does that capture intoxication with cannabis, and how are they doing that? I think there's a lot to unwrap here that we're going to keep pushing on as part of this work.
Okay, thank you very much. I appreciate that.
And I'll just add one thing too, in terms of, we know from research that's been done in other states, and we believe the same to be the case here, particularly with children, but also with adults, around perceptions of the impact of marijuana use on your driving abilities and sort of safety. And there's sort of particularly among kids, there's a perception that this is a natural, totally safe product and does not impair your ability to drive or anything like that. So that's also why when we think about our education campaigns, going a little more upstream on the public health side, we really have to make sure that we have the right messages around the truth of what, smoking, vaping, or whatever with cannabis, what the impact is on your body and what that can mean in terms of impairment.
Yeah, absolutely. And thank you for saying that, Elizabeth. That's why it's so important as part of this public health framework to have these messages out there and to change these perceptions that it isn't always safe or isn't safe to drive impaired. And that includes with cannabis or even other substances. So that's, one of the key points we want to drive home with our impaired or drugged driving campaigns. And also, there's certainly a delay with cannabis use as well. It might not impact someone until 30 minutes later. So, there's definitely things that we need to bring and points to bring to the public.
Just looking to see if there are any other hands. Thank you so much for your presentation. I did have one more question, and it's sort of, it's built off of Delegate Chisholm's started to ask this, but the rate of participation, I know so much of this data collection is around this survey process, and what have you seen in terms of rate of participation, and do you have a good assurance of accuracy of participation as well? Like, what is the data set that you're working with, and the rate of participation with the surveys?
So in regards to the youth risk behavior survey, my office actually implements that survey as well. So we work with a contractor. We have surveyed, I would say, close to 65,000 students. I don't know, I can't remember the exact breakdown. I think it was 40,000 high school and the remainder middle school. So we follow CDC protocols to implement this the survey. They're very strict. We have to reach a certain response rate before we can even use the data. We have met that every year. And because it's such a large sample size, we are able to break it down into local level. So each county has their own data as well.
Thank you so much. That is very impressive.
Yeah.
And thank you so much for all of your work. I know that this subcommittee and this committee are very committed to not just ensuring that the public has awareness around around the dangers of cannabis, but also that we are looking at how cannabis can benefit our communities, and also making sure that we're looking at everything through the lens of making our communities healthier. So thank you so much for your work, and we look forward to being a partner going forward.
We really appreciate your time and the opportunity to speak with you today. And just as follow-up notes for us, we will get back to you on the question related to the Cannabis Legal Resource Center. We also, once we have, we were so excited to show you what we had data-wise, even though it was preliminary. We will get you a cleaner and more easy to understand with better colors version of the data piece. So you can see what we have and what's available. And then we had another item as well. Oh, we will make sure to continue to make the point with the council, but also ensure that we're doing it internally around, yes, this is the public health response. This is not just about youth, but to Delegate Hill's point as well, we are really talking about the entire spectrum. While youth mitigation is key, just because it's not legal for use and consumption, but this is about the entire, life force. So we want to be aware of that and ensure that is being addressed.
Thank you so much. With that, I think we are wrapping up, and if I could have a motion to adjourn.
Motion to adjourn.
Second.
All right. Thank you so much, everyone. We are adjourned. We will see you at 1 o'clock for bill hearings.